been talking a lot about obesity already this morning, I think. Oh, there it's on now. So, well, this has become a national epidemic among all our patient populations, men, women, pregnant, not pregnant. It's especially worrisome during pregnancy because of both the significant short and long-term morbidities that it can impart both on the mother herself, but also on the fetus. So we're going to talk a little bit about that this morning. At Hopkins, one of my colleagues, Janice Henderson, one of the other MFMs, created the clinic for moms who fell into the obese category that they could either self-refer or physicians could refer to. It's kind of like a one-stop shop to try to address all the issues from behavioral therapy to diet to the monitoring for the morbidities of pregnancy and looking for the comorbidities that might already exist as they enter pregnancy. One of the staff, and I'm not sure it was a physician or nurse staff, initially had the scathingly brilliant idea of calling this clinic and labeling it in the appointment system as the Obesity and Pregnancy Clinic. You can imagine we didn't have much uptake on that. However, when it was changed to, when Janice decided to change it to nutrition and pregnancy, that had a much more favorable outlook to patients, and now that clinic is actually pretty full with a waiting list to transfer into there. And I'll talk a little bit about some of the multidisciplinary successes that we've had with that. Oops. Okay, so the objectives for this session are to become familiar with the Institute of Medicine recommendations for weight gain in pregnancy, which have changed over the years, and a little knowledge on the required nutrients for normal fetal growth, to address the management of obesity in pregnancy in order to optimize maternal and fetal outcomes, and to discuss the impact of prior bariatric surgery in pregnancy, because more and more of our patients are coming to pregnancy having had bariatric surgery of different forms. And then finally, and I think, again, much like some of my other talks this morning, particularly Zika, to educate patients regarding the complications of obesity during prenatal and intrapartum care, and like my other two talks, to think about these things before they actually become pregnant. So I have no financial conflicts related to this presentation. So let's look first at the scope of the public health problem among women. So if you look at the definition of BMI, because all of these are going to, a lot of our standards that we're going to talk about today are with respect to varying classes of BMI. Normal, or underweight rather, is less than 18 kilos per meter squared. Normal weight is a BMI of 18 to about 25. Overweight, more than 25 to about 30. And then obesity is over 30. And quite honestly, up until recent years, that is where it stopped, until obesity became such a problem in the United States that now the obesity category is divided into classes 1, 2, and 3. And we can actually layer out some of the comorbidities in terms of risk factors in each of those as well. So in order to monitor this, the CDC has the Behavioral Risk Factor Survey surveillance system. And you can actually go online and pull up annual prevalence estimates, and particularly for your state or region as well. You can look at it as a whole population. You can look at it as women only or men only, depending upon what your patient population and what you're interested in. If we go back to 1990, so almost 20 years ago now, you can see that the way the surveillance system monitored this was really in 3 percentages, in terms of less than 10% of the population was obese, fell into the obesity category, so greater than 30 BMI, or 10 to 14%. So they didn't even go higher than that. Isn't that interesting? Then in 2000, 10 years later, they actually had more categories of obese, or of percentages of obese population. So they went up to greater than 20%. And if you watch where the sort of peachy tan colors are, and look at 215, but if you notice, here is percentage greater than 20, Now they're layering out the percentages as well. And so you can see that the obese states just got more obese. And the less obese states also went up. So this is a little bit of a sad commentary. These are for women. I took these out just looking at for women only. So how did the obesity in this country become such an epidemic? And the National Geographic back in 2004 had an article about the heavy cost of fat, and they proposed 3 areas: calories, culture, and commerce. You could probably hit the nail on the head there. And you can probably think of things that are in our popular culture that are attached to the calories that we eat and also the money in our pockets. So let's look at the Institute of Medicine's recommendations and try to get a handle on this. Why is this so important in pregnancy? Well, we know that women who come into pregnancy obese are more likely, believe it or not, even though they, I'm sure in their heads, know better than that, but they are more likely to overgain weight because they think, for one, they need to gain as much weight as the average built person, when really those recommendations have layered out a little bit more over time. And secondly, they may be less likely to lose that weight and get back to their pre-pregnancy weight. So it's just stacking the weight on top of the weight on top of the weight. And it makes it very hard, and then when they get to menopause, to be able to think of even getting back to a healthier weight. So what constitutes proper weight gain? If you take a look at the 1990 Institute of Medicine guidelines for weight gain, you can see that if you had a low BMI, you could gain up to 40 pounds, normal up to 35, high up to 25, and obese up to 15 pounds. However, the current guidelines have actually backed that up a little bit. So 25 for the normal and 15 for the obese, no more than 15 for the obese category now. And in fact, in many of our patients who are morbidly obese, we try to maintain them at no more than about 10 pounds of weight gain. And if you look at how those guidelines evolved over time, you can see back in the 40s, they kind of waxed and waned here. Back in the 40s and 50s, obstetricians and family practice doctors were telling mothers not to gain more than about 20 pounds, with the idea that that would help them to reduce the risk of toxemia and birth complications. In the 70s, however, we were worried about having too many small babies or SGA babies, and so the recommendation was for everyone across the board, no matter your BMI, to gain about 24 pounds. But you know, when you say about 24 pounds, your patients as a whole, not necessarily as an individual, but as a whole, tend to creep over that a little bit more and a little bit more. So what we got ourselves into was this swirl of patients gaining too much weight and not being able to get rid of it afterwards. And in addition to that, in looking at some of the outcomes in terms of fetal growth, we finally got some data to suggest we didn't need that much weight gain. So in 1990, and between 1990 and 2000, the Institute of Medicine and other researchers took a look at this weight gain recommendation, and based on pre-pregnancy BMI, low BMIs could gain a little bit more, high BMIs should gain a little bit less, but what the real aim was in looking at the data was that everybody had average for gestational age babies. We didn't have to aim for the big fat babies, because a fat baby is not necessarily a healthy baby. So the rationale for the current weight gain guidelines in pregnancy, again, graded based upon your pre-pregnancy BMI, also takes into account the number of fetuses. It takes into account that adherence improves outcomes, as weight gain is often a proxy for nutrition, although you have to be very careful about that because not all our patients have access to adequate nutrition, so you have to talk about what that looks like as well. One of those things that we try to address in our nutrition and pregnancy clinic. And the patients are more likely to follow recommendations with guidance and reinforcement from the doctor. So just telling them or them reading in a handbook that this is all they should gain is probably not going to help. They need that reinforcement, they need that encouragement, they need that pat on the back when they come in visit after visit, and they've been able to maintain their weight or only gain slightly. They start out with a high BMI. Some of the considerations, however, it's all well and good to say let's decrease our weight gain in pregnancy, but some of the considerations that the Institute of Medicine didn't really address in their rationale for these recommendations included that it may serve to decrease the incidence of SGA. So in the earlier recommendations, that's what they were trying to do. And with the underweight, that's obviously what you're trying to do. But it does not consider the excessive incidence of large for gestational age babies that we have in this country currently. It does not also consider the weight retention by mothers, so it doesn't address what to do after the pregnancy in terms of weight retention. And the other thing that puts us in a little bit of quandary here is that there's a recommended increase in weight gain for teenagers in non-Hispanic Black women due to their epidemiologic increased risk for small for gestational age babies. However, this is the same population. So, we're darned if we do, darned if we don't. This is the same population who's at increased risk for significant obesity. Probably because their weight gain is tied to what their nutrients are. So you have to be able to change their nutrients. And we've had a tough time in East Baltimore doing that because we have this sort of wasteland around us in terms of appropriate grocery stores, if you will. And I presume that many of you in some of the pockets of your population have the same problem. So again, weight gain in those Institute of Medicine recommendations really is a proxy for nutrition. But it's up to us to dig down a little deeper and help to educate our patients on what those nutritional considerations are. So let's take a look at managing some of these nutrients prenatally. So yes, we can counsel patients on the ideal weight gain early, including telling the patient that she's obese. Those are difficult conversations, but you have to tell them that. You're doing them that favor, and you can do it in a kind way, and you can do it in a way that says, hey, we're going to partner in this together to work to either maintain weight or postpartum to help you lose weight. They do have to understand this is not a time to diet. So because when you start to tell them of all the things that they're going to be at risk for, like preeclampsia and diabetes, then immediately they're going to want to think, oh, I have to diet. But this isn't a time to diet either, even for the morbidly obese patient. It is a time to be able to maximize intake of healthy foods. So what Dr. Henderson has done that I thought was quite unique in our clinic is we have the Eastern Food Market not far from us that has relatively low-cost fruits and vegetables and other healthy choices there. And then there's also, I won't name the name of the grocery store, but there's another grocery store that's close by that has some of those things, but they're going to be at a little bit higher cost than they are over at the Eastern Food Market. In the afternoon, our NIP clinic, Nutrition and Pregnancy Clinic, is on Friday mornings. And on Friday afternoon, she sets aside once a month to take the patients. And usually she'll be able to cycle through all of them in a couple of months by doing it that way. She will take the patients and go for a walk down to Eastern Market and go for a walk over to the other grocery store and help to point out, if you have this much money to spend, these are the things that are going to give you the highest impact in terms of your nutrients rather than your calories. I got to hand it to her. She ought to get a Nobel Prize just for doing that. But most times we don't have the opportunity to do that. But if you have someone volunteering in your clinic, or if you have, like we do, a cadre of medical students, or you're willing to take some of your admin time maybe once a month, that is something that seems to have made a great impact and is commented on frequently by patients in terms of asking them at the end, what are some of the things that helped you with behavioral lifestyle changes? I'm hoping that Janice publishes some of that soon. This is also time to monitor weight, and as I mentioned before, give the patients feedback. Interestingly, feedback verbally, not just putting it on their chart, but having a discussion with them about their weight gain has been shown. There's actual evidence to show that it reduces excessive weight gain by 40% by having that discussion with the patient. And again, stressing that while those fat babies might be cute, they're not necessarily healthy babies, and we're going to talk about some of the epigenetic reasons why. Nutrition is both for short and long-term outcomes and can be tied to both prenatal delivery and postpartum complications, as we'll discuss. Some of those birth outcomes include preterm delivery, low birth weight, growth restriction, and small for gestational age. And just because you gain a lot of weight doesn't mean you're going to have a baby who's large for gestational age or is not going to be growth restricted because of the comorbidities that can go with that. The fetal outcomes, that's another very interesting area to think about here, because you all have probably heard about the Barker hypothesis. But we know that in children born from mothers who have gained excess weight or obese throughout their pregnancy, particularly the morbidly obese patients, that they have a higher incidence of being obese in childhood and later in life themselves. And that this may epigenetically have something to do with the in utero environment. So your genes are going to set the stage, but the function of those genes can be modified by the metabolic environment around you. And that is one of the leading theories behind why we're seeing a higher incidence of obesity in children and adults who were born from mothers who, again, gained excessive weight or were obese during the pregnancy. So let's go back to the nutrients for a minute. Here is a list of some of the key nutrients that are important in pregnancy, particularly iron and folate. And you'll notice here they're listed now as daily recommended intakes. That's the same as the acronym formerly known as recommended daily allowances. And you can see that the typical iron intake in our diet is about 15 milligrams per day. In pregnancy, we need to double that. And the important thing for patients to know, again, the real food sources are going to be better absorbed and more beneficial than the supplements. Just going and taking a supplement isn't going to be all that helpful. For moms who have a deficiency in iron, there's that lends to both poor outcomes for them as well as for the fetus, including for them hemorrhage tolerance, wound healing, their immune function. It's also been associated with an increase in postpartum depression. For the fetus, we see an increased association with low birth weight, preterm delivery, low APGARs, and potentially in severe anemia, the poor oxygenation can lead to increased mortality and hinders development of mental and psychomotor functions later on. For folate, that should have been micrograms there. So for folate, we recommend in pregnancy for the woman who's not at risk, as you know, 400 micrograms per day. However, in the patient who is at risk, and that's going to include these morbidly obese patients, that goes up to 4 milligrams. That also is the same as what you would recommend for patients who had a prior neural tube defect or patients who had who are on medications that interfere with folate metabolism, such as many of your anti-epileptic drugs. There's also been a link to potential folate deficiency in the development of autism. So that's some emerging data we'll need to keep an eye on. Calcium, actually, there's no increased intake requirement. The problem is that most women don't get the daily recommended intake in the first place. And so if they're deficient going into pregnancy, it increases their risk for preeclampsia as well. Hence the reason for adding calcium into their diet. Vitamin D, again, that's important in regulating placental development and function. Deficiencies can lead to defects in fetal bone development and also increase the risk for preeclampsia and gestational diabetes. Iodine, we heard a little bit about that this morning when we were talking about thyroid disease. But if you look down this list in terms of sources, the most important source is not the supplements you take. It's the food sources that you can get. And a lot of our women are of lower socioeconomic status may not have the finances to be, or even be in an area where they can easily buy these types of food stores. Okay, so in summary, if you look at nutrient daily required intakes, most of them are going to increase in pregnancy. more than calories. So it's the nutrients, again, that are important, not so much the increase in calories that are important. Although we do talk about for a singleton pregnancy in a normal BMI patient, an additional 300 kilocalories per day is recommended. Now, that also has to take into account where is that person starting in their BMI, what is their daily activity level. So we have a nutritionist that sits down with our mothers in the nutrition and pregnancy and goes over their daily activity, and they have them keep a log for a week or two, goes over their current calorie intake and the types of calories that they're taking in, and then of course whether they're carrying singleton pregnancy or twin pregnancy, and they'll factor all of that into giving them a dietary plan. There's one other comment. I just had a brain lapse there that I was going to make about that. One other thing, for those of you that live in more rural areas where there's not city water that's fluorinated, fluoride supplements are still not recommended. Again, because they can be absorbed by the fetal bone, and the dietary requirement doesn't really change for that any more than it does for other fat-soluble vitamins or for calcium, and so it's not recommended that if you don't buy bottled water with fluoride in beforehand, you don't necessarily need to add it in now. So how about looking at those? That's a little bit about nutrition and nutrients, a little bit about recommended weight gain. But now what are we going to do differently for the prenatal care of the obese patient other than counsel them about their weight and other than talking to them about nutrients? So prenatal care does look a little bit different. First of all, we want to do early dating and viability because we know that there's about a 20% increase in miscarriage rate among patients that are obese. And when I have these numbers up here in terms of incidence or odds ratios, those actually are averages for all three classes of obesity. And if you were to break that out, it increases with the increasing level of BMI, so the increasing classes of obesity. There's an inaccuracy sometimes in the determination of a woman's due date because she may not come in with an accurate last menstrual period because of having anovulatory cycles. There's an increased incidence more than threefold of recurrent miscarriage and an increased incidence of fraternal twinning. So if you thought it was a problem to have a singleton and be morbidly obese, twins are not more efficient in this case. Because we know that twinning adds on, maybe not completely additive, but adds on risks in terms of diabetes and preeclampsia, just to think about some of the common morbidities. We want to screen these patients early. Remember I said earlier that even with our autoimmune disorder patients, we do a lot of diagnosis for the first time in pregnancy of that particular set of comorbid conditions, but the same happens with chronic hypertension and diabetes. A lot of these women aren't seeing a physician on a regular basis. Hopefully, if they had been, someone would have been working with them on their BMI in the first place. So we do a lot of diagnosis at that new OB visit of chronic hypertension and diabetes. The other thing we need to take a close look at is obstructive sleep apnea. Because as you know, in any obese person, particularly the morbidly obese, obstructive sleep apnea is a real problem. And in pregnancy, not only can it cause low oxygen events, but it also increases the risk of developing preeclampsia later on in pregnancy. And of course, these women are at risk for DVT. So on morbidly obese patients, we put on baby aspirin. And I might just take a minute to put in a plug and mention here that the U.S. task force, the USPSTF, so the task force on looking at some of these dose recommendations for nutrients and for other drugs, has recently recommended use of low-dose aspirin after 12 weeks in gestation in women at high risk for preeclampsia. These morbidly obese patients certainly fall into that category. There are other risk factors as well: history of preeclampsia, multifetal gestation, chronic hypertension, diabetes type 1 or 2, renal disease, and autoimmune disorders, as we talked about earlier. And this is a relatively new in the last couple of months recommendations. So there's a lot more people who we would recommend to have on a baby aspirin a day or low dose 80 milligrams per day. But as you can imagine, these obese patients, once we've completed their screening, are likely to have more than one of those risk factors anyway. If they are in a class 1, for example, obesity category, and they have no other comorbid conditions, that's sort of a soft call there. That's not on the more strict recommendations. We also have difficulty with prenatal diagnosis in pregnancy. As you can imagine, not all sonograms are created equal, and thickness of the abdominal wall makes it much more difficult to diagnose not just neural tube defects, but other anomalies as well. And then certainly we're going to start immediately with that nutrition referral to help ameliorate excessive weight gain and improve nutrition, set goals and set limits for the patients. And we're going to continue to go over those. You all are very likely familiar with the screen for obstructive sleep apnea, the stopgap. Do you snore? Are you tired frequently? Have you been observed to stop breathing or choke and gasp when you sleep? Do you have, or are you being treated for high blood pressure? What's your BMI? These patients are going to be no for older than 50 in most cases, not all. I had a 54-year-old and a 56-year-old last year that were pregnant. One fell into the obesity category, the other didn't. Neck size and looking at gender, and of course these patients are going to be female, but you look at their scores here and it'll tell you what their risk is for obstructive sleep apnea, and if they fall into the intermediate to high risk, we're going to refer them to our sleep clinic. In addition to that, we are going to do this every trimester, because remember, despite our best efforts, they're at increased risk for excessive weight gain and compounding this problem. So this is looking at some of the data for increased congenital anomalies in patients who are obese, and this was taken from the recent ACOG practice bulletin, but was also published in JAMA in 2009. And you can see that while neural tube defects and spina bifida are the highest risk for these patients, there is still an increased risk for cardiovascular anomalies, cleft lip and palate, anorectal atresia, hydrocephaly, and other limb reduction defects as well over the average patient. And when you look at detection, you look at standard and targeted sonography, you can see here that as you increase the class of obesity, it becomes more and more difficult to pick up those anomalies and be able to appropriately evaluate and consult the patient. Later in pregnancy, we're going to repeat the screening again, because now we're looking for not just chronic hypertension, but we're looking for superimposed preeclampsia. We're going to do the diabetes screen at the beginning of pregnancy and again at 28 weeks in these patients. Continue to monitor their weight and nutrients. We get serial growth ultrasounds after the 20-week anatomy screen on these patients because of their risk, not just for LGA, but a certain percentage of them are also at risk for growth restriction. We watch them very closely for metabolic development of metabolic syndrome in pregnancy, acute fatty liver pregnancy that they're at increased risk for. We have a conversation and educate them about the signs and symptoms of preterm labor. And at 37 weeks, in patients that are in the obese category, and it is increasingly so with the increasing classes of obesity, there is an up to 40% chance of in utero fetal demise near term. So at 37 weeks, we put these patients in antepartum testing twice a week, so NSTs twice a week. We also get anesthesia consults in these patients. As you can imagine, for our morbidly obese patients, and even some in the lower classes of obesity, if they have a short neck or a thick neck, and other comorbid conditions, many of them have asthma as well, they are a little bit of, they are a little bit of an anesthesia nightmare, and we want them and their babies to have good outcomes, so we want to be prepared ahead of time. We also want to make sure that they deliver by a reasonable date, so we typically, especially if their cervix is favorable, try to get them delivered between 39 and 40 weeks. However, induction of labor for comorbidities is quite frequent, but induction of labor usually takes a lot longer in these patients than it does in a normal BMI patient. And on top of that, you have all the risks of failed induction of labor, cesarean section, infections. All of those things compound the problem. So if a patient can lose even 5% of her weight, as you were recommending for some of the menopausal patients before too, even 5% before they start their pregnancy, there actually is seen incremental reductions in these risks, not just during the pregnancy, but also for the intrapartum care. Preoperatively, if we are going to be performing a cesarean section on these patients, we want to work together and with any other physicians that are caring for them as part of the team, including the anesthesiologist, the primary care doctor, if they have a cardiologist or an endocrinologist. We want to go through the comorbidity evaluation and make sure that their conditions are optimized prior to surgery. We want to make sure anesthesia has had a chance to do a good physical exam and take a look at their airways. If necessary, we get a chest x-ray or an EKG or an echo. Many of our morbidly obese patients who have other comorbidities are at increased risk for developing cardiomyopathies in pregnancy. There is something up here that's making me cough. I was not coughing sitting back there. Excuse me. And then we want to talk to them about the possibility of having to do invasive monitoring, prolonging intubation, and using CPAP postpartum as well. The more that they're involved and understand what the risks are and their families, I shouldn't say the less scary it is, but the more accepting and the more they understand why these things happen. And I don't know, maybe I'm superstitious, but I always tell them, we're going to go through all these bad things that can happen because I believe them, they won't happen. And they're like, yeah, they're not going to happen then. So they ask a lot of really good questions. Respiratory changes. It's important for us to realize what some of the respiratory changes that are going to occur in pregnancy that are normal, that are listed on the left there for you, but also what happens if you add obesity into that. And while these are not strictly additive, they do compound each other. And so that is also important, especially in the obese patient who has other respiratory problems such as asthma. And in our population, we have a high degree of asthma in the inner city. Cardiovascular changes, as I mentioned, they are at increased risk for cardiomyopathies in pregnancy, so we watch them very closely. On the left, we have the normal changes that occur in the healthy pregnant patient, and then the changes that occur in the obese patient, and again, they are somewhat additive, hence increased work on the heart. And if somebody's had long-standing hypertension, their heart may not be able to withstand that increase in cardiac output necessary to manage that increased blood volume and increased work during labor. Patients who have had a cesarean section before, oftentimes they were a little bit less in terms of their BMI that first pregnancy, because remember we talked about the fact that it's often additive and they don't get back to their pre-pregnancy weight. But they remember that it wasn't necessarily pleasant and that there were other risk factors and maybe other complications they had, such as wound infections if they were obese with the first. And many come in very desperately wanting to have a vaginal delivery the next time, especially if they were obese the first pregnancy and had those complications. But I think we have to have a frank talk with them about that as well, because labor is not completely without increased risk for them either, as I mentioned earlier. So if you look at the various levels of BMI, you can factor that in terms of vaginal birth after cesarean success rate. And in fact, there is a calculator called the Trial of Labor After Cesarean on the NIH, and it takes into account their BMI along with the other factors for the reason for their first section, their height, their weight, and to a certain extent, I think it does factor in some of the ethnic categories as well. But BMI plays a big factor in those calculations and being able to counsel patients in terms of evidence for their success rates. Because what you don't want to have is somebody who you've induced for 3 days who's morbidly obese and then baby starts not tolerating labor and having to do an urgent section, and maybe now they've developed chorioamnionitis on top of that. That is really a disaster waiting to happen. While you all may not be doing a lot of cesarean deliveries, it's probably good for us all to know about some of the increased preparation that we need to do for these patients who are morbidly obese, including different surgical tables. Most of our surgical OR tables only manage up to 400, some 500 pounds. And it is not uncommon for some of our morbidly obese patients to be right on the edge of the 400-pound, which I think is what ours are at my institution. 1 in 3 failed intubations occur due to morbid obesity, and so oftentimes it's better to do awake intubations. But then the OR tables need to be able to position the patient into a little bit less supine, more sitting up in order to be able to decrease compression of the airway. And this is the 7th leading cause of maternal mortality, is failed intubation in obese patients. Pre-oxygenation can't be stressed enough because that's going to give us more time to try to successfully do that. Intraoperative antibiotics, we always give these prophylactically. However, you need to increase the dose for obese patients. And because the surgery is going to take longer, if it's longer than 4 hours, you need to redose the patients. Incision. You need to prep the patients about this ahead of time too, because in patients who have a very long pannus, you oftentimes will need to do a supraumbilical incision. The other choice is a vertical infraumbilical incision. And for patients in which you can successfully pull the pannus up, and there are special drapes that are made for this now, without compromising her respiratory effort. Actually, the fan and steel incision is not a bad choice, because just above the suprapubic line, it's kind of the great equalizer in terms of the thickness of the adipose tissue there. So if you can do that, great. There are increased risks of postoperative wound infections, but it's both in the literature and in my own experience, it works really well to take peri-pads. And as often as they're going to change their peri-pad for their lochia, they change the peri-pads under the pannus to keep that dry underneath that, and they usually do quite well. So again, an ounce of prevention is worth a whole pot of gold, and planning, so communication with the patient, communication with the staff, communication with their primary care providers or other physicians who are helping to manage their comorbid conditions. Identify and refer them early, whether it be for nutrition or other subspecialists. Alert anesthesia and NICU at labor onset, and I would recommend that all of these patients have anesthesia consults before they come in to deliver. Aggressively recommend epidural placement. It's still difficult to put the epidural in some of these patients who have folds even on their back. However, we saw that the 7th leading cause of maternal mortality is failed intubation in obese patients. If we can avoid that, the better. Also, you may not be able to anticipate and avoid a crash cesarean section. So if you have the epidural in place and it's working, that's going to be helpful to you. And we talked about some of those other things. Postpartum care. Early ambulation really is not just for the cesarean section patients. In our obese patients, this is for the vaginal delivery patients as well. You want to get them moving around as part of their DVT prophylaxis. SCDs, if they're going to be in bed for a while until they are able to ambulate. And 12 hours after delivery for the class 3 BMI, we will start enoxaparin, 40 milligrams daily as prophylaxis until they go home and they're up walking around on a regular basis. Nutrition referral and exercise, because again, if you can't help them get back to their pre-pregnancy weight, even if they were obese to start out with, but to lose whatever weight they gained, even if it was only 15 pounds, we're doing them a disservice for not helping them to address that, and exercise. Monitor their comorbidities. That handoff back to their primary care provider is oh so important. You may have felt comfortable managing their chronic hypertension or their diabetes and pregnancy, or their counseling them about their obesity and working on behavioral changes, but somebody's got to pick up the ball after that 6 week. And just to say bye, go call your PCP. It's so, so important to make sure that they get a handoff, whether it's written or verbal. And then birth control is an issue because you don't want that decreased interval between pregnancies. Again, because they're not going to even have the opportunity to get back to their pre-pregnancy weight. but also we know that short interval pregnancies, less than 6 months to a year, can affect the fetal growth on the subsequent pregnancy. So a quick word about the impact of bariatric surgery in these patients. So we're seeing a lot more patients coming into us that have had bariatric surgery prior to their pregnancy. And one of the things that we really need to address, and we hope that their primary care providers and their bariatric surgeons have addressed if they express the desire to get pregnant, were their nutritional deficiencies. And I say that tongue-in-cheek about the express the desire to get pregnant because we know that 70% of pregnancies in the United States are unplanned. That doesn't mean they're unwanted, they're just unplanned. So having addressed that ahead of time and making sure their nutritional status is appropriate is very important. The other thing is we know that patients will have overall better outcomes, so we don't want to dissuade them from the bariatric surgery, even though we have to address their potential nutritional deficiencies. But we know that the literature is showing that these women who have bariatric surgery have decreased gestational diabetes and hypertensive disorders, they have decreased macrosomia, decreased incidence of congenital abnormalities, and childhood obesity in their offspring. Not so much, the jury's still out on whether it's going to have any effect on preterm delivery or cesarean delivery and the complications afterwards. But that's a pretty big deal if you can impact the outcomes in terms of hypertension and diabetes. There are different types of bariatric surgery, restrictive and malabsorption, and some are a combination. Here's a picture that sort of depicts what those are. The Roux-en-Y is where they have taken a loop of the bowel, the small bowel, and they brought it up to the antrum of the stomach. And then they sever that so the food all goes through here with a loop of the duodenum coming down and attaching so that the bile will be excreted through there. But as you can see, by bypassing this portion, there's going to be a big hit in terms of some of the digestion and absorption of nutrients. So in this particular type, you really have to watch and monitor closely both preconception and each trimester the nutrient levels in these patients. There's the adjustable lap band in red that just basically constricts the upper portion of the stomach. And then sometimes there's a combination of gastric stapling along with an adjustable band as well, or gastric stapling by itself just to decrease the volume of the stomach. Regardless of the type, it's recommended that patients delay conception, if that's their ultimate goal, for 12 to 24 months, because in that first 12 to 24 months is presumably when they're going to have the rapid weight loss. And rapid weight loss is associated with fetal demise and also with growth restriction in the fetus. So you want to try to avoid that, in which case you want to make sure that they have some form of contraception during that time. And that goes back to your talk you had on contraception yesterday. For these patients, potentially the estrogen containing may compound their increased DVT risk already, so you might want to think about an IUD or a progesterone containing. Certainly they can use condoms, but then that relies on behavioral modification there as well. But the important thing is that there's contraception used until they're cleared. You also want to make sure that when the patient comes to you, you coordinate care with your bariatric surgeon so you understand what type of surgery they had. It is not frequent, but not uncommon either, that for the patients that had the adjustable lap band, that they may have to have some adjustment as pregnancy goes on. So you really want, if they start complaining of pain and having other side effects, that you have already been in touch with their gastric surgeon, their bariatric surgeon early on to partner with them in monitoring these patients. Again, we talked about monitoring preconception acute trimester for key nutritional deficiencies. These patients, we will also monitor their growth, probably even more so if they conceive in the first 12 to 24 months afterwards. But most of them don't go from being morbidly obese to non-obese. Most of them go from being maybe a class 3 to a class 1. So they still qualify for enhanced monitoring. The other thing is, I mentioned earlier that you want to screen these patients for diabetes at the new OB visit, and then again at the beginning of the third trimester at 28 weeks. But in these patients who have had bariatric surgery, particularly the malabsorptive types, you need to be very careful. It is almost certain, of course in humans it's never 100%, but almost certain that if you give them that very highly concentrated glucola, that you're going to cause an episode of dumping syndrome for them. So with those patients, we're more likely to teach them how to use the glucometer and to profile their sugars for a few days and bring those in on their current diet, rather than causing more problems for them. And finally, how are we going to counsel these obese patients? Because really that conversation, which we said even from early on, calling it what it is. They're obese, what category are they in? Let them look at that. Share with them the statistics, depending upon their level of education and what you think they're going to understand. Everybody understands diabetes. Everybody understands high blood pressure. And if they don't understand the word preeclampsia, they've probably heard the word toxemia before from their mothers or their grandmothers. But they all understand the disasters that can happen in pregnancy. And more importantly, they have a strong desire to have a good outcome for their baby. So this is a good time to have those frank discussions with them in a kind manner. Both the March of Dimes and ACOG have put out very nice information for patients that you can share with them. Most of them are adjusted to the 6th grade reading level, but as you know, sometimes medical terms can't be watered down to that, so it may require more one-on-one discussion rather than just handing them the information. It is important to have those critical conversations and give them some rationale for behavioral change. Pre-conception, it's to optimize their comorbidities that may already exist. To lose, even if it's 5% of their weight loss, and show them how that can incrementally decrease the risk for their babies and for them. In the new OB visit, it's to set goals, again to optimize comorbidities, to talk about the risks so that they can understand why we're being so strict with those goals, to help improve their physical activity and start working on behavioral change, and to talk about long-term outcomes for their infant, because that starts early on, not in the 3rd trimester. And then postpartum, to really focus on the mother herself, weight loss, getting back to her pre-pregnancy weight, the appropriate birth control, and to talk about safe pregnancy intervals. And again, I think more so than for the mother herself, sometimes she'll blow off the risk to herself. I know I blow off everything that has to do with me if I have something for my family or something for work to do. But if they're thinking about that their behavioral change is going to have an impact on the early development of their child, and to talk about how their obesity affects the body growth and composition of their child, the metabolic programming of their child in terms that they can understand, and the later life morbidity. Nobody wants to think that what they're doing now is going to cause their child to have diabetes and high blood pressure as an adult. I think we've gone through most of those things. Oh, we did not talk about birth trauma, but that certainly is a risk. So for the LGA infants, there's always the risk of birth trauma from shoulder dystocia. And if you think shoulder dystocia is only a problem with the vaginal delivery, that would be wrong. It is very difficult when a mother has a big, thick abdomen to deliver a baby even by cesarean section. It is not a gentle procedure. It still looks pretty barbaric, and it's still a lot of pulling and tugging, and can cause birth trauma for the infant. So in summary, childbearing contributes to the long-term development of obesity in women. So we know that peri-pregnancy period is critical in terms of talking to them about their pre-pregnancy obesity, helping them to avoid excessive weight gain, to get rid of that weight postpartum, and to avoid high parity, which just tends to add on top of the previous pregnancy, and to also help them with ongoing behavioral change and diet coaching during the inter-pregnancy interval. And again, even 5 to 10% of body weight loss will improve the health for the mother and for her infant. And I think in our experience, anecdotally, that's where I start to see mothers light up and understand what the problem is here. This is a picture. I had to put one picture in. This is my daughter-in-law, my grandson, who will be a year old in August. And he is at the 95th percentile, and she's this tiny little thing. She was probably underweight when she got pregnant. But again, she has the luxury of being able to have good nutrients during her pregnancy. So he's at the 95th percentile because he's 95th percentile in height, not in weight. But this is what I hope for all of our patients. Thank you. Oh, question. I almost forgot. Oops, let's go backwards here.
I got you.
Oh, you've got it.
I get you. I think.
I'll make sure I have them here so that. Oh, maybe I didn't bring them up with me so I can actually read them. Here we go. Oh, I did. Here we are. Okay, number one.
The first one's not loading, so just go ahead and.
Okay, I'll just read it to you.
Yeah.
So the first one is a 24-year-old patient, G1P0, so she's never had a baby before this is her first pregnancy, presenting for a new obstetric visit at 8 weeks. Her past medical history is insignificant, except that she currently weighs 345 pounds and has a BMI greater than 40. You counsel her that A, overall she should stay within the range of 11 to 12 pounds of weight gain to optimize maternal and fetal outcomes. B, iron is an important nutrient in pregnancy and has better absorption and bioavailability if taken as a supplement. C, a fat baby is a healthy baby. And D, you recommend she take 400 micrograms of folate daily to reduce the risk of neural tube defects. Which of those is accurate? Okay, so about 2/3 of you answered A, which was the correct answer. Overall, she should stay within the range of 11 to 20 pounds of weight gain to optimize maternal and fetal outcomes. Another section, about 1/3 of you answered D, you'd recommend 400 micrograms of folate daily. But in actuality, in that morbidly obese category, she's at increased risk for neural tube defects, so we would give her the higher dose of folate in pregnancy. Okay, number 2. Oh, that one loaded. And we have answers already. So your 24-year-old prima gravida has not had regular medical care. Since she was in high school, you explained that since she's morbidly obese, you recommend screening at her first visit and again later in pregnancy for the following comorbidities and all of the above. So diabetes, obstructive sleep apnea, and hypertension, all of which can be associated with increasing the risk of obstetric morbidities, preterm labor, preeclampsia, and diabetes in pregnancy. The third question is antenatal testing should be offered to all obese pregnant mothers at 37 weeks to screen for the risk of developing, and you said in utero fetal demise. That is true because we know that there's an increased risk, particularly after 37 weeks, and more so as that classification of obesity increases. Next question is a 35-year-old woman who presents for preconception counseling immediately after her bariatric surgery. In counseling her, which of the following recommendations is incorrect? And that is, and we almost all got this right, attempting pregnancy as soon as possible because she has multiple risk factors for infertility. Well, she may. However, the other risk factors are more important in terms of fetal development at this point, so we recommend they wait 12 to 24 months afterwards. Okay, the last question is patients who are obese during pregnancy increase the risk of long-term effects for both themselves and their child. These long-term effects of maternal obesity might include all of the following except chromosomal disorders. And the idea of childhood obesity, heart disease, diabetes, high blood pressure really comes probably from the epigenetic programming that occurs from the gene products in utero. Okay, questions? Yes, ma'am.
Low molecular heparin postpartum, is that for vaginal deliveries as well as C-sections?
Actually, we do for vaginal deliveries as well as C-sections. For the morbidly obese patient, we put them on prophylactic heparin until they go home. Now, I have a couple of patients who did not want to take it, but they were stars and they got up after vaginal deliveries and started moving around like crazy. But we still do the SCDs, the sequential compression stockings, when they're lying down and sleeping at night, if they're refusing the heparin or that low molecular weight.
Just until they go home or 6 weeks?
Till they go home.
Till they go home.
Till they go home.